Yes, sir, we are live.
Yeah, Tahar.
Yes, sir, we can start.
Hello.
Hello. Yes, sir.
Are we live, Tahar?
Yes, sir, we are live.
Yeah. Good evening, all doctors. I hope my audio is clear. I am Purushottam Patel from Zydus Synovia. Welcome you all on the online learning platform Roma DG Conclave. Today we are having with us well-known consultant rheumatologist from Pune, Dr. Gayatri Ekbote. Welcome, ma'am.
Thank you.
Thank you very much for your time for today. Dr. Gayatri Ekbote is a consultant rheumatologist practicing in Pune. She is having her own hospital in Shivajinagar, Pune, also attached with Vijay Medical, Sancheti Hospital, Pune, and Dinanath Mangeshkar Hospital, Pune. Today, doctor will be taking us through the very interesting topic, approach to arthritis. I request if you have any question during the session, you can type during the session in chat box at the bottom of the screen. We will take all your queries at the end of the session. So this is all from me. Over to you, ma'am. Yeah, ma'am. You can.
Yeah. Am I visible?
Yes.
Okay. So good evening, everybody, and a very happy new year to all of you. I would like to thank Zydus Pharma, first of all, for giving me this opportunity. And thank you, audience, for joining us today. So today I'm going to talk about approach to arthritis. So I think we all know what does arthritis mean. So Dr. Helen has described that the word arthritis just does not mean joint inflammation. This term is used to describe actually around 200 different conditions, and it just does not affect joints, but it also affects the tissues which surround the joints, other connective tissues, along with systemic inflammation. And that's why, as a rheumatologist, for me it is very important to let you all know that we are internist first, and then we are rheumatologists. That's why since any arthritis is a systemic illness, so I think that needs to be paid attention to. So whenever a patient with joint pains comes to us in OPD, we address these 5 questions: whether is it articular or non-articular, whether the duration is acute, which is less than 6 weeks, or it is chronic, is it inflammatory or mechanical? I think this is the most important question. And we need to know the patterns of joint involvement and whether a patient has any other associated symptoms. So I'm going to deal with each question one by one. Okay, so as we all know, so this is a simple diagram of a joint. So as we all know, the articular structure consists of the synovium. So that's why clinically we say that patient has synovitis when we say that patient has arthritis. Then there is a synovial fluid. Then there is the articular cartilage. There are intra-articular ligament. Then there is a joint capsule, and there is juxta-articular bone, as you all can see. The non-articular structures which are around the joints are tendons, muscle, bursae, nerves, skin, etc. So as you can see, the joint is quite a complex structure. So whenever we have a articular problem, usually the pain is both on active and passive. But in non-articular problem, the pain is usually on the active movements. In articular structure, there is limited range of motion, whereas in non-articular, there could be limited range of motion, but there could be focal tenderness. Swelling is usually with articular problem, and you can see deformity definitely. So let's address which are the non-articular conditions first. So I think we all see these conditions. These are quite common conditions which we see in our day-to-day practice. So in shoulder, we have rotator cuff tear, frozen shoulder, which is quite common in diabetics. Then we have subacromial bursitis, rotator cuff tendinitis. In elbow, we have medial or lateral epicondylitis, which is commonly known as tennis elbow, or olecranon bursitis. In wrist, we have decurvent stenosynovitis, trigger finger, Dupuytren's contracture. Again, these are very common in diabetics. In knee, we have different types of bursa. So any bursa could get affected. So bursitis. In hip, we have GT bursitis, iliopsoas bursitis, adductor tendinitis. In ankle, we have Achilles tendinitis, which is quite a common condition. Then we have calcaneal and retrocalcaneal bursitis. In foot, we have very common condition, which is known as plantar fasciitis, deforming problem, which is known as hallux valgus, or a little benign conditions, which is known as Morton's neuroma. We need to know these conditions because these conditions mimic inflammatory arthritis sometimes, or this could be secondarily, these conditions could be present secondarily in the presence of inflammatory arthritis. So yes, the most important question is whether is it inflammatory or non-inflammatory. So in our second year of pathology in Robbins, we have read that there are 5 signs of inflammation, which is rubor, calor, dolor, loss of function, or tumor. So at least 2 signs should be present to call it as an inflammatory arthritis. So either swelling, erythema, warmth, tenderness, or stiffness should be present. Usually in inflammatory arthritis, the pain is in the early morning or whenever patient gets up. It is because of the inflammation. There is decreased lymphatic drainage. That's why there is the stagnation of inflammatory fluid. That's why we get pain as soon as we get up in inflammatory arthritis. Whereas in non-inflammatory conditions like degenerative conditions like osteoarthritis, etc., the pain is usually in the evening after a certain period of activity. So it's more of a fatigue or pain, which is after a certain period of activity, whereas inflammatory pain does get better after the activity. In inflammatory activity, we all have read it in our MBBS that early morning stiffness is quite prominent. Reason I told you. Since inflammatory arthritis is usually a systemic disease, so we have systemic features like fever, loss of weight, sometimes cough, or some rash, depending on the underlying condition. Inflammatory markers are quite are often raised in inflammatory arthritis. Synovial fluid WBC count is usually high in inflammatory conditions, but whenever it is associated with sepsis, etc., the WBC count is extremely high. Examples of inflammatory conditions includes infectious causes like septic arthritis or crystal arthropathy like gout, which is the most common arthritis in males at least, followed by rheumatoid arthritis. So crystal arthropathy examples include gout or CPPD or pseudo gout, immune mediated, obviously, which include rheumatoid arthritis, SLE, dermatomyositis, mixed connective tissue disease, spondyloarthropathy, etc. Then reactive arthritis, which is again a subtype of spondyloarthropathy group. Then vasculitis associated arthritis. Non-inflammatory conditions include osteoarthritis. Though it is itis, it's a misnomer. It is non-inflammatory condition. Then it overuse tendinitis or bursitis, trauma. Then neoplasm like PVNS. Then the most important thing is fibromyalgia or metabolic causes like osteoporosis or any vitamin deficiency. These are the diagnosis of exclusion usually. So these conditions can mimic inflammatory arthritis. So these are few of the examples of inflammatory and non-inflammatory conditions. Okay, so I think in our MBBS or any medical training, the history taking has been taught very well, and that is the most important part till today. So history taking is very important. So as I said, acute arthritis or acute arthropathy is said when the disease duration is less than 6 weeks, and chronic when it is more than 6 weeks. Then pattern of joint involvement is very important. I'm coming to that. Then we have to know which are the aggravating and relieving factor. Early morning stiffness, axial involvement. So we have the axial skeleton, and we need to know whether patient has any back pain, cervical pain, etc. Whether patient has noticed any swelling, any drug history, that is very important. Whether patient has any fever which is preceding or accompanying, whether patient has any preceding history of loose stool, urinary tract infection, IV drug abuse. So these things are very important while you take history. Okay, so whenever we, so this is the pattern. So monoarticular, as the name suggests, usually it is the single joint involvement. Most of the times monoarticular involvement is acute. So again, in inflammatory conditions, monoarticular, the examples are infectious arthritis, gout, pseudogout, or reactive arthritis. Then sometimes rheumatoid arthritis or spondyloarthropathy can present with just one joint involvement. Then bursitis, tendinitis. Non-articular conditions include trauma, fracture, or RSD. So the chronic monoarthritis or oligoarthritis by definition includes 2 to 3 joint involvement. The chronic conditions are in non-inflammatory domain. We have osteoarthritis, osteonecrosis or AVN, neuropathic or Charcot joints, hemochromatosis. This is little rare. Then PVNS. Whereas in inflammatory conditions, we have psoriatic arthritis, undifferentiated spondyloarthropathy, some indolent infections. India is hub of COX, so we need to know that polyarticular or enthesitis related arthritis, which is a part of juvenile inflammatory arthritis, pseudo gout, etc. And nowadays we are seeing a lot of post-COVID arthritis, so that condition also need to be addressed. So polyarthritis, this is important and little complex domain. Acute, whenever the duration of polyarthritis or joint involvement is more than or equal to 4 in adults or more than or equal to 5 in children. Whenever it is acute or less than 6 weeks, the non-inflammatory condition include hemoglobinopathy like sickle cell anemia, thalassemia, etc., amyloid. But these are little rarer conditions. Acute polyarthritis, inflammatory conditions are viral arthritis, chikungunya, dengue, and post-COVID, serum sickness, drug-induced. There are multiple drugs. I'm going to come to that later. Early onset connective tissue disease. Many a times we see that SLE or any myositis or sometimes scleroderma or mixed connective tissue disease can present with just acute polyarthritis at the start. Then we have to ask for other history. Rheumatic fever. This is not quite common condition nowadays thanks to penicillin, but yes, rheumatic fever can present with acute polyarthritis. Palindromic rheumatism, which is a type of intermittent arthritis. RS3PE, which is remitting synovitis and pitting edema. Then chronic conditions include osteoarthritis, chronic polyarthritis, prototype is rheumatoid arthritis. Then there is certain condition which is known as undifferentiated inflammatory arthritis, which does not fulfill criteria for any of the arthritis. Then connective tissue diseases, as I said, SLE, etc. Polyarticular juvenile inflammatory arthritis and adult onset Still's disease. This is little rare, but yes, this could be sinister if not treated properly. So I think this diagram will sum up everything. So first, carpometacarpal joint is commonly involved in osteoarthritis. Then decurvent stenosynovitis usually affects the lateral part of the wrist. Then we have wrist involvement, which is quite common in rheumatoid arthritis, pseudogout or CPPD, or gonococcal arthritis, juvenile arthritis, or carpal tunnel syndrome. So carpal tunnel syndrome is not really a part of, is not a type of arthritis, but any arthritis can lead to median nerve compression and lead to carpal tunnel syndrome. In rheumatoid arthritis, MCP involvement is quite common. Then certain other conditions like pseudogout or hemochromatosis can lead to MCP involvement. PIP, that is proximal interphalangeal joints, can get involved in osteoarthritis, SLE, rheumatoid arthritis, psoriasis, etc. However, DIP involvement or distal interphalangeal joint involvement is a little special. Rheumatoid arthritis does not affect distal interphalangeal joint. So the DIP joint involvement is commonly seen in psoriatic arthritis, reactive arthritis, sarcoidosis, or in little rarer types like multicentric reticular histiocytosis, etc. Predominantly lower limb arthritis is usually seen with spondyloarthropathy group in your undifferentiated SPA or angspond, in reactive arthritis or IBD or Crohn's disease or ulcerative colitis associated arthritis, sarcoidosis or osteoarthritis, which is a non-inflammatory condition. So predominantly lower limb arthritis is seen in these conditions. Intermittent arthritis, by definition, it means the arthritis which comes and goes. So the most important example is palindromic rheumatism, then gout, reactive arthritis, and pseudogout. So palindromic rheumatism is basically an umbrella term, and any of the arthritis. If patient has sometimes, the patient can sometimes have MCP involvement, wrist involvement, rheumatoid factor could be positive, but the joint involvement could be intermittent. So we need to pay attention to patient's history, and we need to document synovitis before starting any disease-modifying anti-rheumatic drugs. Gout, as we all know, it is extremely tender, mono-articular disease, and when our patient gets gout, he or she usually does not forget. The attack is usually so severe. Reactive arthritis, we know that usually arthritis happens. The fever is usually preceded by the arthritis. Pseudogout is kind of similar to gout, but difference is usually in the crystal examination. Migratory arthritis, As we all know, the arthritis of rheumatic fever is fleeting. So whenever suppose we have wrist involvement and then later we can have MCP involvement. So whenever MCP gets involved, the wrist involvement can go away. So this is actually a migratory arthritis. So this is typically seen with rheumatic fever, sometimes with sarcoidosis, in little rarer conditions like Whipple's disease. Bacterial endocarditis and SLE also can present with migratory arthritis. So again, we have to ask which are the real aggravating and relieving factor. We have to know whether patient has any early morning stiffness which lasts more than 30 minutes. So we need to know whether the patient joint pain worsens with rest, it decreases with activity, it decreases with NSAID, steroids, etc. The early morning stiffness is excessive, whether is it more than 30 minutes, whether the patient has night pains, especially in spondyloarthropathy group, patient has alternate buttock pains and patient cannot sleep in one position, he or she has to turn in the night. So we have to ask about all these things. Predominantly axial involvement is seen with angstpond or in angstpond group like psoriatic arthropathy, reactive arthritis, enteropathic arthritis like Crohn's disease or ulcerative colitis. In countries where unpasteurized milk is used, Brucella arthritis is quite common, which leads to sacroiliitis. In rheumatoid arthritis, axial involvement is rare, but it can involve cervical cord. And when it is involved, cervical cord is involved in rheumatoid arthritis, it is an emergency and patient needs evaluation and treatment urgently. So yes, when patient says that the joint pain is associated with swelling and pain, it almost rules out non-inflammatory cause, sometimes rules out fibromyalgia also. In India, yes, we all wear a lot of rings, especially females. So they will tell when the PIPs get involved, they will tell that the rings get tight. Sometimes they have difficulty in wearing bangles. In the village, patient will say that they have difficulty in milking the cows. They have difficulty in doing day-to-day activity. So simple histories like that is very important. Yes, many drugs can lead to multiple rheumatologic conditions. The steroid is a double-edged sword. It can cure the condition as well as it can lead to different conditions. So myalgias or myopathies usually are associated with excessive use of glucocorticoid, hydroxychloroquine, statins, cyclosporin, quinolones, interferons, etc. Arthralgias or tendinitis is usually associated with excessive use of quinolones, protease inhibitors, ARTs, interferons, etc. Then gout is typically seen with diuretic overuse, pyrazinamide, I think we all know about it, alcohol, it is a very notorious cause of gout, sometimes ethambutol. Osteonecrosis or avascular necrosis is caused by steroids, alcohol, bisphosphonates. Bisphosphonates usually lead to atypical fractures also or atypical AVN of jaw. Osteopenia, the decrease in bone mineral density, is usually seen with steroids, heparin, phenytoin, methotrexate sometimes. Scleroderma, thickening of skin, is usually seen with pentazocine, tryptophan, organic solvent. These drugs are not very commonly used, but there are case reports. Vasculitis, allopurinol, cocaine, TNF inhibitors, montelukast, thiazides, propylthiouracil, these are all associated with vasculitis. Montelukast typically leads to Churg-Strauss syndrome. Drug-induced lupus, drug-induced SLE, which is caused by isoniazid. We see quite few patients of SLE, drug-induced SLE after isoniazid use. Hydralazine, ACE inhibitors, phenytoin, carbamazepine, ticlopidine, etc. These conditions are rare, but we need to take drug history in detail because you never know any of the drugs, any of these drugs can lead to any of these diseases. So fever, rash with arthritis. So this triad is quite common in adult onset still disease, SLE, dermatomyositis, certain bacterial infections like staphylococcal infections, streptococci, typically bacterial endocarditis associated with these infections, Neisseria gonorrhea, Lyme's disease. Then viral infections, as we all know in India, hepatitis B, hepatitis C, HIV, these are quite common. Chikungunya is quite common, dengue, and now we have COVID, but COVID usually leads to reactive arthritis. So fever usually is before arthritis. Then in Western countries, we have parvovirus, etc. Serum sickness reaction, it is little rare, but this needs to be taken, this needs to be kept in mind. Okay, so the most important thing is reactive arthritis does not have fever at the onset of arthritis. So, preceding loose stools or IV drug use is usually seen with reactive arthritis, bacterial endocarditis, septic arthritis, or enteropathic arthritis. So, all these diseases can have loose stools, and we need to ask them about history of IV drug abuse. Extra-articular manifestations, as I said earlier, rheumatologists are physicians first. So we are not just doctors of joints. We have to address extra-articular manifestations because these are very important. Mucocutaneous involvement. So let's start with mucous membrane involvement and skin involvement. So in parvovirus associated arthritis, we get facial exanthema. In SLE, we get to see typical malar rash, which is a part of acute cutaneous lupus, which is photosensitive rash. We get chronic cutaneous lupus, which is discoid rash. In dermatomyositis, we get typical Gauton's papules or heliotrope rash. Of course, in psoriatic arthritis, we have psoriatic plaques. In Behçet's disease, SLE or Crohn's disease, we have oral ulcers. In certain conditions like sarcoidosis, enteropathic arthritis, we have erythema nodosum. I have pictures of all this. In antiphospholipid syndrome, we have a lace-like thrombotic rash, which is known as livedo reticularis. The vasculitis or typical non-blanching rash due to capillaritis is seen with HSP, ANCA-associated vasculitis, cryoglobulinemia, etc. In reactive arthritis, we get to see typical keratoderma, blenorigica, cercinet balanitis, etc. In scleroderma or in poems, we get to see skin tightening with skin hyperpigmentation. So this is erythema nodosum. So obviously we can just appreciate the redness. These are elevated rashes. This is usually inflammatory fat necrosis. So these come in crops. These are quite tender. Usually the sites are seen of the tibia. So these EN or erythema nodosum or paniculitis with arthritis is usually associated with sarcoidosis, post-streptococcal arthritis, sometimes with SLE and enteropathic arthritis, Behçet's disease, etc. This is a typical sarcinet balanitis with keratoderma. This is seen with reactive arthritis, and this is quite common in arthritis with certain STDs also. This is typically psoriatic rash. This is a vasculitic rash. This is non-blanching rash. So you can have petechial purpuric non-blanching rash due to capillaritis. So this could be associated with HSP in children or ANCA-associated vasculitis or any CTD. Arthritis with oral ulcers. So oral ulcers are typically seen on the hard palate, and these are painless, and these are associated with SLE, Crohn's disease or Behçet's disease. So these are typical. This is a typical heliotrope purplish rash around the eyelids. These are Gauton's papules. These are seen on PIPs, MCPs, etc. This type of rash is seen with dermatomyositis. Ocular involvement is very important because obviously one cannot lose eye, and sometimes eye disease could be very sinister. It could be benign, but it could be sinister. So spondyloarthropathy or sarcoidosis could be associated with uveitis. Wegener's disease, spondyloarthropathy, SLE can have conjunctivitis. Rheumatoid arthritis or again systemic necrotic vasculitis can have scleritis, and scleritis is a very bad disease and needs to be treated properly. Then we can have ischemic optic neuritis, which could be sudden in onset. This usually is seen with certain large vessel vasculitis like giant cell arthritis or Takayasu arthritis, or sometimes with small vessel vasculitis like Wegener's granulomatosis. So this is typically red, angry eye of scleritis. So yes, systemic symptoms. You have to ask patient about all these symptoms. So you can have cough with hemoptysis in Wegener's granulomatosis or granulomatosis with polyangiitis. Sometimes rheumatoid arthritis can have ILD and they can have cough, or sometimes all these patients, these could be on immunosuppression. So they can have coughs. So cough and hemoptysis history is very important. Again, weight loss, appetite loss, shortness of breath, hearing loss, otitis, epistaxis, scleritis, uveitis, Sicca syndrome. These all are systemic symptoms, and these could be either present with vasculitis or any connective tissue diseases. Tingling and numbness. These denote underlying peripheral neuropathy, and sometimes patients, the neuropathy could be the first manifestation. Bloody diarrhea is typically seen with IBD associated arthritis or Crohn's disease or ulcerative colitis. Muscle weakness, very important. Then we have to ask about history of nasal regurgitation or dysphagia. Parotid enlargement is typically seen with Sjogren syndrome, but patient can have hepatitis B, hepatitis C infection. So these can have parotid enlargement with arthritis. Other history, fatigue. All patients with CTDs or inflammatory arthritis, they have underlying a lot of inflammation going on. So they have extreme fatigue. So fatigue could be present with inflammatory conditions or with non-inflammatory conditions like fibromyalgia. Altered sleep pattern in patients with fibromyalgia, the sleep gets disturbed. Patients can have irritability, forgetfulness, headaches, etc. So they can have history of blood transfusion or some surgery some surgery done, or you have to ask whether patient has got any procedures done, CAG done or any surgery done. The stent arthritis can be seen post PTCA. So everything is important. You have to ask just history. The first visit of the patient is very important. So especially in countries like India, when the cost is the issue, and especially for the physicians who work in government sector, history taking is very important because our patients cannot afford so many investigations. So at the end of the history, for novice people, at least 70% diagnosis should be clear, and for experts, sometimes it could be 90%. So at the end of the history, obviously we'll come to know whether condition is acute or chronic, it is inflammatory or non-inflammatory, depending on the joint pattern, whether it is mono, oligo or polyarthritis, whether patient has axial involvement, whether patient has extra-articular manifestation, has any systemic symptoms. So at the end of the examination, so the examination should be done on the bed initially. So patient should be made very comfortable, and then you have to look for gait if patient is able to walk. But the most important thing is patient should be made comfortable whenever you are examining the patients with arthritis. So in rheumatoid arthritis, typically 28 joints are involved because I think you all have heard a score which is known as DAS 28 or disease activity score 28. So in these, knees, both wrists, all PIPs, MCPs, shoulders and elbows are included. We have to examine for ankles also, though ankles are not involved or included in DAS 28 score. Coming to examination part, general inspection. As soon as patient gets into the room, we have to see how patient is coming to the room, how he or she is sitting on the chair, or how patient is going to the bed. We have to see the general appearance, whether patient appears cachexic, malnourished. We have to see whether there is any apparent wasting, etc. Then whenever you are doing the examination, just look for the asymmetry between the sides, look for the obvious swelling, look for the deformities, any atrophy, any erythema. Then look for active range of motion. Just first of all, have patients range the joints, then watch decreased or increased movements. Watch for the pain. Whenever patient gets a lot of pain, just stop doing examination because nobody will like the doctor which makes patient very uncomfortable. Listen for the crepitus. Watch for any abnormal movements. Then passive range of motion. Then just you have to do this. You have to range the joints passively. Again, note whether any movement is decreased or increased, whether patient has any pain with the movement. Again, look for the crepitus. Look whenever you do palpation, so you have to know the anatomy. Just palpate the swelling, palpate for the warmth. Basically look for the inflammation. So after doing the local examination or joint examination, go for the systemic examination, which we have been taught in our undergrads. So look for the skin, start with head to toe examination. Look for the skin, whether patient has any obvious rash. In scalp, you have to see whether patient has any alopecia. We still have many cases of Hansen, so look for the eyebrow thinning. Then ophthalmic evaluation, as I said, is very important. You can have collapsed nasal breach in conditions like Hansen's, granulomatous polyangiitis, etc. In certain vasculitic diseases like ANCA-associated vasculitis or GPA, you can have ear discharge. In relapsing polychondritis, you can have ear cartilage destruction. Nails are very commonly involved in psoriatic arthritis, but sometimes you can have digital infarct and splinter hemorrhages like patients with bacterial endocarditis, or you can have Raynaud's phenomenon in patients with scleroderma, MCTD, SLE, etc. Since connective tissue diseases or inflammatory arthritis, these are diseases of reticuloendothelial systems also, look for any palpable lymph nodes. Neurological examination, look for muscle strength, straight leg raising test, reflexes, whether patient has any mononeuritis multiplex like wrist drop or a foot drop, and this could be an emergency. Look for polyneuropathy. Ascites could be a part of polycirrhositis. Look for hepatosplenomegaly. In respiratory examination, in Angst-Pont, in the severe or the progressive cases of Angst-Pont, the chest wall expansion could be reduced. Then listen for the crepitations. This usually happens with any pneumonia, with any inflammatory conditions, or with any arthritis or CTD presenting with interstitial lung disease, pleurisy and pleural effusion. These could be present in patients with active SLE or rheumatoid arthritis, etc. Ascending aortitis or AR murmur, you have to listen, look for these, especially in patients with large vessel vascularitis like Takayasu arthritis. Conduction abnormalities, look for the new onset murmur, arthritis and fever. These are usually seen with bacterial endocarditis or any myocarditis associated with SLE. Then look for pericardial effusion. Then as I told about nail examination, you can see onycholysis, clubbing, pitting in IBD, Whipple's disease or psoriatic. You can have parotid enlargement in Sjogren syndrome. In amyloidosis, we can have macroglycia. In gout, we can have tophi. In scleroderma, we can have telangiectasias, which are dilated blood vessels. And spondyloarthropathy or psoriatic group or sarcoidosis, we can have dactylitis, the swelling of the wall of the digit. So this is a typical photo of dactylitis. This is not just joint. This is the swelling around the joint, and this is so the whole digit is swollen in hands and in the foot. So this is known as dactylitis. So yes, at the end of the history and clinical examination, 90% of the diagnosis is made, and rest 10% is just supportive. Investigations, we have to order minimum. There are certain basic tests which should be done before starting any immunosuppression. So in basic test, we have CBC or hemogram, which includes ESR. Sometimes you can do CRP. Liver function test, renal function test should be done baseline. Then when you are starting certain drugs like methotrexate, etc., LFTs and CBC should be monitored. India is again a hub of many viral infections, which include hepatitis B, C, HIV. So you have to know before starting certain synthetic DMARDs or before starting certain biologics, we have to get all these, the viral screening done. Thyroid diseases are great mimickers of inflammatory arthropathy or CTD. So you have to do thyroid function test. Look for diabetes. Diabetes chorioarthropathy is quite common. Chest X-ray should be ideally done in all the patients. Arthritis specific investigations. So rheumatoid factor and anti-CCP, whenever you feel that patient has rheumatoid arthritis like pattern or some atypical arthritis which is not fulfilling any of the criteria, so then do rheumatoid factor and anti-CCP because these have prognostic value. ANA should be done whenever you feel that patient can have SLE or patients can have CTDs. When a patient has arthritis, fever, or some skin rash or muscle weakness, etc. Patients with predominantly lower limb arthritis or back pain or in axial involvement, please do HLA-B27. ENA profile or ANA blot is just the study of extractable nuclear antigens. So these are the certain specific antibodies against certain antigens in the nucleus. Synovial fluid analysis, this is usually done to differentiate septic arthritis from gout or any other monoarticular involvement. Sometimes it is very difficult to detect synovitis by just physical examination, but patient can have symptoms like early morning stiffness, etc. So that time musculoskeletal ultrasound is very important to detect early inflammatory arthritis or to rule out inflammatory causes from non-inflammatory causes. In Angst-Pont or in spondyloarthropathies, the X-rays cannot detect early changes, so that time MRI of sacroiliac joints is very important. Indication for synovial fluid, as I said, monoarthritis should be done. Synovial fluid examination should be done usually in all cases of acute monoarthritis. Then for therapeutic purposes, as I said, whenever you have high index of suspicion for septic arthritis and for crystal examination. I won't get into the details of synovial fluid examination. So arthritis accompanying systemic diseases. So these systemic diseases could be there and they can have arthritis, except diabetes. These are little rarer conditions apart from, I think, diabetes and hypothyroidism. You can have certain conditions like carcinomatous polyarthritis, amyloidosis, hemochromatosis, sickle cell anemia, some paraneoplastic etiologies, etc. So these systemic diseases can have arthritis. Okay, so to conclude, history should be sought in detail. Examination should include all systems and not just one joint or the joints involved. A proper history and examination can help reduce the cost of investigations to the patient. Avoid starting DMARDs or any immunosuppressive till you are sure about the disease, because once you start these conditions, the disease can melt, and it is usually because once you start the DMARDs, it is very important because you cannot stop the DMARDs, and stepwise approach is always beneficial. So thank you.
Yeah, thank you very much, doctor.
Yes.
We have few questions in chat box. So
Okay.
I will start with the questions.
Yeah.
One question is, what is the choice of therapy in active rheumatoid arthritis when patient is coming to you first time?
Okay, so rheumatoid arthritis, once you are clear and sure about the diagnosis, just when you have baseline tests with you, so the bridging steroid, first of all, we start with bridging steroid over 4 to 6 weeks, but we have to start, taper and stop. Then the methotrexate is anchor drug, but you have to rule out all contraindications like hypersensitivity to methotrexate, whether patient has any history. Pregnancy is a big no-no. Then the second drug is hydroxychloroquine. Then there are other drugs like leflunomide, sulfasalazine. Then there are certain targeted synthetic DMARDs or biologic DMARDs. But methotrexate is the anchor drug and usually the first line therapy in rheumatoid arthritis in along with steroids and NSAIDs.
If primary drug is not working, then what is the second line of drug for rheumatoid arthritis?
So first of all, I need to know which is the primary drug you are using. So if by primary drug you mean methotrexate, then increase the dose of methotrexate. Suppose you have started patient on 15 mg of methotrexate once a week, then you can increase methotrexate to 20 or say 25 mg. If patient has poor prognostic factors like polyarticular involvement, erosive deforming RA and RFC-CP are positive in very high titers, you can start the patient on leflunomide. It's a good approach to start patient on methotrexate and leflunomide combination. So if the patients do not respond well to these drugs, then you can go for newer drugs like tofacitinib, which is a targeted synthetic DMARD, or you can go for biologic therapies like rituximab or anti-TNF inhibitors like infliximab, etc.
Okay. One question is on gout. How long should a gout patient to be kept on drug after controlling acute attack?
Sorry, I didn't get the question. How long?
How long should a gout patient to be
Gout,
kept on
okay.
drug after control of acute attack?
So according to the newer guidelines, colchicine usually we use to control the acute attack if patient does not have contraindications. So colchicine, at least 2 weeks, colchicine should be given, and then you start with ULTs. But nowadays they say that you can even you can give colchicine even as a prophylaxis for at least 3 months. But the acute attack, the gout treatment includes for acute attack you have to give colchicine at least for 2 weeks before starting them on urate lowering drugs.
Okay. How you see the role of new DMARD, that is igorotimod in arthritis, RA, active rheumatoid arthritis, and ankylosing spondylosis?
So I have not used iguratimod so far, but it looks like a promising drug and it has been used by many of my colleagues. So there are studies coming up. So I think it's a good drug. It can replace. It's a good drug with safety profile. But there are certain newer DMARDs, targeted synthetic DMARDs, which are FDA approved, like tofacitinib, baricitinib, etc. And then
Yeah,
we have
one question
biologic
is there
DMARDs.
regarding that only. Any comments on JAK inhibitor role?
So JAK inhibitors are in the picture since 2013 and 14, but now since the price has come down drastically, I think we are all are open to use JAK inhibitors in many diseases. So JAK inhibitors are good, but you have to keep in mind that it should be used by experts, and you can use JAK inhibitors in rheumatoid arthritis, ankylosing spondylitis. We have been using JAK inhibitors like tofacitinib in psoriatic arthritis, etc. But you have to do the baseline investigations like CBC, LFT, RFT. You have to see whether patient has any contraindications. You have to rule out all viral conditions. Then pregnancy is a big contraindication, but the studies are quite promising, and tofacitinib is a good drug. Baricitinib and tofacitinib. Tofacitinib lately, many of my colleagues and even I am using. So it's a good drug, but you have to monitor the patient well.
Okay, one question from Dr. Mahesh Budwal. What is the drug of choice in ankylosing spondylitis? What is the best exercise for that?
So there is nothing called as the best drug in any of the diseases. It is always individualized. But if you say drug of choice, then yes, NSAIDs, initial NSAID therapy is the most important in angst because it's an inflammatory condition. Then if it is associated with peripheral arthritis or enthesitis, you can start patients on sulfasalazine or methotrexate, etc. The best exercise depends on the joint or the structure involved. Whenever it is low back, the low back strengthening exercises, swimming again is very good. Then obviously the exercises of the involved joint. I think we can have physiotherapists next, so they could answer better.
So these are all. This is all about these questions from chat box.
Okay.
So I am not seeing any questions. So I request all doctors, if any question, please put immediately in the chat box. We will hold for 1 minute, doctor.
Okay. So regarding just two more things like JAK inhibitors, tofacitinib, because it inhibits the JAK pathway. So that's why it is a very good anti-inflammatory DMARD. So that's why, but JAK inhibitor is not everybody's cup of tea. So I want everybody to understand that whenever you start using JAK inhibitors, at least have one opinion from rheumatologist before starting patients on JAK inhibitors, because its safety profile needs to be documented well, and there are multiple contraindications, and the monitoring has to be very strict. And nowadays we have a newer entity coming up, which is post-COVID reactive arthritis, so that also needs to be addressed. So do we have any questions?
No, doctor.
Okay,
That's all.
thank you.
Yeah. Thank you very much, doctor, for your time.
Yeah.
I would like to thank all the doctors who have taken their time and attend today's sessions. So thank you very, very much, all the doctors, and thank you, especially thank you very much, ma'am, for your valuable time.
Thank you so much.
Yeah, thank you.
Yeah.